there what is the realized? Nothing. It's only review article. Orthopedic religion. International. This is only the articles only. IJO is the standard one, right? International orthopedic format is for IJO. Review article and it also IJO. International Journal of Orthopedics and Orthopedic Sciences and IJOS. Sure, complete article do you know? Read the title.
Valgus intertrochanteric osteotomy for femur neck pseudoarthrosis, a simple solution to a complex problem that has stood the test of time.
So what is pseudoarthrosis here?
Like fibrous unions in
pseudoarthrosis in neck, right?
Yes.
Femoral neck.
It at the fracture site, femur neck fracture sites.
But can you call it pseudoarthrosis?
Because of sometimes there will be formation of fibrous joint. That is called pseudoarthrosis.
I don't think it call it pseudoarthrosis in neck. It can be non-linear, different types of non-linears are there. Fibrous non-linear, complete solid non-linear. I don't know why this call it pseudoarthrosis. You're not a long bone to say pseudoarthrosis there, no?
Yes, sir.
Neck.
Yes, sir.
Neck, does neck have periosteum there?
Periosteum will be there, sir, but periosteum will be there, sir, but cambium layer is absent.
How do you call the pseudoarthrosis then? A simple solution to a complex problem. So how many they have done? From 29 to only 2-3 years finished.
Yes, sir. In 2000, they didn't give any sample size, sir. They this is in a review article.
How many cases they have done to prove that it is a good procedure?
There is no sample size, sir. They have just done review article over different researchers.
The articles are three. One is a research article, whether they have done any study, like a retrospective study, a cohort study, matched control study, something like that. This is a technical note. Okay, so you should tell that. Case, is there a case reports like or procedure? This is International Orthopedics. It's the official journal for SICOT. SICOT is the International Society for Trauma. Yeah. So this is International Orthopedics. That's only the journal name. Next time you know any journal, you can put the impact factor. What is the value of the study? How many citations it has got? Then you will know.
Okay, sir.
So there is no journal in the name that you have put.
Okay, sir.
You can see there is written received and accepted date and then
SICOT.
SICOT is nothing.
Okay.
The title of the journal is SICOT only first.
Okay, sir.
వస్తున్నాడా
కింద వస్తున్నాను
గేటుకి పోడు ఒకటి కదా రైట్ why I'm asking is because they are giving the article to read and then go through that. Let him come and have a discussion here.
Okay,
Right.
So first
See that you read this? Read the abstract and then proceed.
Good morning, everyone. Today I am going to discuss about the role of valgus intertrochanteric osteotomies in femur neck fractures non-union. Femur neck non-union in young patients have always been a difficult problem to deal with for surgeons. Numerous surgical procedures to address either the biological or mechanical issues at the non-union have been described, and most of them have been associated with variable results. Isolated biological augmentation is often associated with poor results, and some techniques like vascularized grafting may require not so commonly available expertise. Valgus osteotomy is aimed to correct the abnormal fracture biomechanics associated with femoral neck fractures. By altering the nature of force transmission across the non-union, shear forces are converted into compressive forces that lead to rapid osseous union without the need for bone grafting. Though the principles are sound and were described a long time ago, the technical aspects have evolved over time. Various modifications have been described to overcome shortcomings such as limb length discrepancy, reduction of femoral offset, alteration in mechanical axis, and the overall proximal femoral anatomy. In this review, we look back at the fundamental principles and recent literature on the results of valgus intertrochanteric osteotomy for femoral neck pseudoarthrosis. We also highlight the importance need for accurate preoperative planning and surgical execution. Lastly, we elaborate on the technical improvisations that have happened over time in order to improve functional results and to minimize complications and poor outcome after a valgus osteotomy.
So you have seen here pseudoarthrosis of the neck here.
Yes, sir.
You have seen in this institution. Did you come across a case at least where there is pseudoarthrosis of the neck?
Yes, sir. There is fibrous union. Come across a patient.
That's what I am asking. Did you see anything here?
Yes, sir.
How many?
One patient, sir.
That means undisplaced. Pseudoarthrosis is due to the undisplaced fracture which is there or something else, or is pathological. Pseudoarthrosis also. No? There are the article. Do you know?
Sir, approval.
Correct, but now. Then show what it is. Sir, what made you to select this article? Did you come across anything like
Yes,
this?
sir.
Pseudoarthrosis వచ్చిందా లేకుంటే నాన్ యూనియన్ వచ్చిందా డిలేడ్
Non-union with fibrous union.
ఫైబ్రస్ యూనియన్
Fibrous union is yes, sir.
undisplaced.
And
Both
displaced.
views.
Yes, sir.
Is it proved in the X-rays? Both views it undisplaced with a gap.
This one.
That's what, So what is this case you want to show now? Is it pseudoarthrosis here? What the article says is fracture neck.
Yes, sir.
Must be a transverse here. But this becomes more to the basal now.
This fibrous union is yes, sir.
Okay, but fibrous union is there. That's what I said last time. This is only the delayed union. But you are saying it's a fibrous union of pseudoarthrosis. It's not pseudoarthrosis here. You can see this gone up. The displacement is still there. But what the article shows is showing me that. Femoral leg pseudoarthrosis. Neck is basal. Or fracture neck or subcapital. How do you know this is what? What he meant was a pseudoarthrosis where there is a fracture which is like pathological fractures or mutational fractures, which is metabolic fractures, where it is still undisplaced. They can do this. Other fracture which is gone and migrated up with the pseudoarthrosis. It's not pseudoarthrosis. This is delayed union.
But the
Types of union there in neck is fibrous union, sound union, unsound union in a fracture neck. They have described. Depending on is there a telescopic posture or not, that they have described this. Patient is walking or not, but patient is walking this. Your patient, okay. Right.
So, coming to introduction, in any old patient coming with femur neck fractures or femur neck non-union fractures, the more easier and reliable option is going for hemiarthroplasty. But in young patients, we need to preserve the head. So first we need to understand in which patients we need to preserve head. So various factors like patient factors and femoral head factors have been cited. The observed indication for head preservation is age less than 40 years. Relative indication is age between 40 to 60 years, and patients with active lifestyle and with no chronic diseases, and patients with long life expectancy. Femoral head factors like round head with no segmental collapse, and in fractures with enough bone at femoral head to fix, that is approximately 3 to 4 centimeters. So in all these patients, first we have to we need to try to preserve the head before going for hemiarthroplasty. So today our technique Vito is one such head preservation technique. So what actually Vito is? It is a closed wedge angulation osteotomy used to treat non-union femur neck fractures in young adults by realigning the fracture.
Different, pseudoarthrosis is different.
Okay, sir.
What type of non-union is pseudarthrosis? It's all type of non-union also. But you are saying non-union, frank non-union and neck of femur. Is it the same? Pseudarthrosis and the non-union are both the same.
No, sir.
Right.
It involves wedge resection of the bone and valgization of the proximal femur. This technique was first introduced by Powell, and hence it is also known as Powell's osteotomy. Later on,
Modified by Muller. This is what Powell's only. Powell's osteotomy modified by Muller, which is called abduction osteotomy. That's what the common thing done. There's nothing new in this, right?
later on it was popularized and applied for the purpose of femur neck fractures by Muller. So before understanding the biomechanics of veto, we need to see what are the actual causes for the non-union of femur neck fracture. The various factors
You
have
are
been.
saying non-union, you are saying pseudarthrosis.
The entire
I don't know what
article is about in the article it is given a non-union only, sir. They have described only non-union about. They have never mentioned any
If it is non-union, you have to get telescoping positive definitely. If it's not there, it's not.
Yes, sir.
Findings are there where telescoping is positive in such cases.
No, sir.
No. Problem is that fibrous union, sometimes you will not get anything at all.
Telescope is negative. Yes, sir.
Only if it is frank non-union, you can get a telescoping positive. Otherwise, you will not get telescope positive.
Yes, sir.
Right?
So the mechanic factors like high fracture angles with Powell's grade 3, where there are a lot of shearing forces that inhibits the healing at the fracture site, and in fractures with small proximal fragment, that like in transcervical and subcapital, which gives very small purchase for the screws within the femur neck, thus inhibiting the stability of the fracture fixation, and in fractures with posterior inferior cortical combination, and in with fractures that are fixed with various fixation. These forms are mechanical factors, whereas the biological factors are like injury to capsular artery blood supply, and lack of cambium layer within the periosteum surrounding the femur neck, synovial fluid interference, and capsular tamponade. So all these factors inhibit the union of femur neck fracture, thus promoting non-union. So what scientists have done is no, sir. It's covered with periosteum but lack of cambium layer, which will not promote any osseous. Okay, sir. It promotes ossification. Cambium, yes, sir. Cellular layer is cambium layer. So veto is one such a technique where the mechanics are altered, thus converting the shearing forces into compressive forces, and these compressive forces promote the fibrous tissue to rapidly mineralize and also promote angiogenesis and endochondral ossification, thus achieving fracture union. So the biomechanics of the veto. Powell has done extensive research on biomechanics of the veto. He has stated that our hip joint is acted upon by two types of forces. First, by the one is body weight, that is in the vertical axis, and the other is the muscular forces, chiefly by the abductors. Yes. Chiefly by the. Yes. Okay, sir. So yes, sir. The resultant force R is a force that is acting on the hip center. This force usually makes an angle of about 16 degrees with the vertical axis and about 25 degrees with the anatomical femur axis. So usually this resultant force is a little medial to the axis of the neck. So because of this, the femur neck is always subjected to different types of forces like shearing forces, compressive forces, and bending forces. But what happens in Powell's type 3, that is where the angle is more than 50 degrees, the fracture line is almost near to vertical, Because of this, the shearing forces will dominate the other forces, that is compressive and bending forces. And because of this shearing forces, the femoral head will go into various fixation, thus inhibiting the fracture healing. So Vito is a technique where it is helpful in converting Powell's type 3, where the shearing forces are dominating forces. The goal of this surgery is to place the fracture perpendicular to the line of the resultant forces, and this requires the fracture angle to be brought to less than 25 degrees, thus converting the shearing forces to compressive forces. Here we can see the fracture line here, which is making an angle of about 65 degrees. Here, after realigning the fracture line, it is we have made it to about perpendicular to the resultant force. Thus, the shearing forces here in grade 3 Powell's are converted into compressive forces. Coming to indications. Valgus osteotomy. Valgus osteotomy, proximal femur will be taken to valgization, sir. Increasing the femur neck shaft angle. Yes, sir. Yes, sir. No, sir. No, no, sir. Coming to indications, well established femoral neck pseudoarthrosis, and with a delayed presentation that is greater than 3 weeks of a displaced fracture with high Powell's angle, and primary veto in type 3 Powell's is a controversial topic. Coming to contraindications, observed contraindication is established avascular necrosis with collapse of the femoral head. Related contraindications are patients with advanced age, smoking, osteoporosis, and small femoral head, that is neck resorption ratio less than 0.52, and in patients with morbid obesity. Coming to preoperative assessment, the patient should be assessed thoroughly for the clinical and radiological assessment like limb length discrepancy, coronal, sagittal, and rotational deformity assessment. And we have to take AP X-rays with traction and internal rotation to know the complete status of the femoral neck. And we need to measure the neck shaft femur angles on both sides for comparison. And we need to calculate the Powell's angle on the fracture side. So once all this information is collected, we will go with the surgery. So the surgical technique of Vito involves mainly 4 steps. The first step is calculating the size of the wedge. Second is choosing appropriate implant. Third is making an entry for the blade or the screw. And the final step is doing the osteotomy with valgization. So how to calculate the size of the wedge? It is given by the formula preoperative Powell's angle minus desired Powell's angle. For suppose here this is in grade 3, for suppose the angle is 65 degrees. Postoperatively, the Powell has given the target angle of 25 degrees to make the fracture line perpendicular to the resultant forces. So the difference between 65 and 25 is 40 degrees. That is how much we have to take the wedge angle here. That is how we calculate the size of the wedge. Sir? Powell has given the fracture angles. Yes, sir. It is a target Powell's angle, sir. Yes, sir. Yes, sir. About 40 degrees will be the osteotomy angle. Yes, sir. In this case. Into calculate, sir. The angle will be 40 degrees. Yes, sir. Yes, sir. Yes, sir. Yes, sir. Yes, sir.
Intraoperatively, you can't keep measuring angle, you not have protractor. No?
Yes, sir.
You will only measure in centimeters
We will set these angles onto paper and we will calculate on. We will calculate.
So is like 1 degree is equal to 1 mm. Suppose you are telling 40 degrees, so we'll cut 4 centimeters as the base. Like what is the logic?
Uh,
What I'm asking, each degree of C is equal to 1 mm base is been cut.
okay, sir.
So how much you want to have this calculation there? 40.
40 degree.
40 mm is how much? How much centimeters?
0.4 centimeters.
That's the height here.
Yes, sir.
Base of the bed
4
should be that
centimeters.
much removed so that it comes to so that is more. That's
So all these X-rays you should calculate on the real magnification, and you should remove the magnification error also. Then only you can tell that 1 mm is 1 degree. Otherwise it will be lesser because wide deviation normally is about 0.8.
Okay, sir. So once the angle is calculated, we will choose the implant. Various implants are available for the V2 technique, like blade plate system and the DHS system. And blade plate is again two types: single angle blade plate and double angle blade plate. The advantage of blade plate system are it leaves a small footprint within the femoral neck and also removes less bone, which has a better rotational stability, which is not seen with the DHS. It removes lot more bone than compared to blade plate system and has a less rotational stability and often requires additional derotational screw. Coming to disadvantage of blade plate system, it requires precise surgical technique and has less intraoperative flexibility. The DHS compensates this, that is it has more intraoperative flexibility and it is easy to use. The other systems that are available are the pre-bent double angle DCS and the contour DCP. You can see this is a double angle blade plate system. You can see two angles. So one big disadvantage of a double angle blade plate system is to accommodate this for this angle, we need to medialize the shaft, so which leads to lateralization of the mechanical axis, thus leading to premature degeneration of the lateral compartment of the knee. So this is one of the big disadvantage. So no, sir. No, sir. Yes, sir. Sir? The yes.
That is the disadvantage. One disadvantage with using a DHS, that you are not putting any graft and there's no contact, so there's a higher risk for non-union. So a lot of people, what they do, whatever wedge you have taken, they reverse that and put it on the medial side so that the compressive forces is intact. That is another advantage with blade plate, that you don't have all that, so angle is maintained. Like servo string, you have that effect.
Yes, sir. Yes, sir. I'll show you the last time. So to prevent lateralization of the mechanical axis, we can use about 10 to 15 mm longer blade plate, or we can replace it with a single angle blade plate or a DHS. So once the implant is chosen, next we need to make the entry for the blade or the screw placement. It is calculated by the formula given by insertion angle, that is implant angle minus the osteotomy angle. Once the insertion angle is found out, we have to start inserting the chisel or the pin, starting from the anterior to being on the anterior to the two-thirds of the greater trochanter. So avoid being on the posterior to prevent any damage to retinacular vessels. And the screw or blade should be in the inferior part of the head of the femur in AP, and in center it should be in the lateral position. Once the blade or screw is placed, the final step is performing the wedge osteotomy and the valgization. The osteotomy site should be at least 1.5 centimeters distal to the entry of the chisel or the screw. So we have to do this osteotomy site should be at least 1.5 centimeters distal. Yes, sir. Okay, sir. Yes, sir. So this is endotrochanteric osteotomy. Here the osteotomy is made just proximal to the lesser trochanter. The one big disadvantage of here is the lateral bone bridge sometimes fails to bridge the gap that is caused due to wedge resorption, leading to lateral wall insufficiency. So to tackle this, there is small variation known as subtrochanteric osteotomy, where the osteotomy is done just distal to the lesser trochanter. This effectively bridges the wedge resorption bone gap, but the disadvantage of subtrochanteric osteotomy is due to excessive muscular forces acting on the proximal fragment, it leads to poor osteotomy healing. So other variations of the endotrochanteric are like sliding osteotomy, also known as a no wedge technique. Here, so this information shows that there is a unit data about problems and complications are involved in veto, or sometimes there will be failure of the fracture union. No, sir. They have just this is a review article in different surgeries. Research that they have done, sir. Yes, sir.
He has quoted his own article.
Yes, sir.
So there is Gavaskar et al. This is his own article. Okay, so he has performed 11 cases with 1 year follow-up and using it is almost 100%. That's what he wants to show. But he has done subtrochanteric osteotomy with no wedge. Antibiotic.
Yes, sir. The problems and complications are like so the main purpose of veto is to achieve fracture at the non-union site, but sometimes there will be failure of the fracture union. This is because of inadequate valgization, shorter blade length, poor position of the blade or screw in the head, inadequate lateral bone bridge, and inadequate bone stock due to neck resorption. While inadequate valgization leads to failure of the fracture union. Yes, sir. The bone that is lost due to wedge resection will be compensated with the valgization, sir. Yes, sir. So the excess valgization increases the incidence of AVN, and excess removal of wedge will lead to limb length discrepancy, leading to limping of the patient. Yes, sir. This is a 16-year-old boy with a 3-month-old non-union femur neck fractures. Here he has came with a chief complaint of pain and limping, sir. He is able to walk. Able to walk, sir. Without support, he is able to walk, sir. Pain and limping. Yes, sir. No, sir. Video, I didn't. Last week, I mean. Last week. The telescope sign is negative, sir. and there is a limb length discrepancy of about 1.5 centimeters. Decrease, sir. And fracture side. It is normal, sir. Slight external rotation is there when compared to the other side. External rotation is and take the photo.
You have the previous PPT, that's why you can't create
Yes, sir.
this PPT with the walking video, then everything will be clear.
Uh,
If you're presenting a case, you should
yes,
put
sir.
all the details.
16-year-old, sir. The femur neck fracture calculated is the 16 degrees, 116 degrees approximately. When compared to the other side is 130 degrees. So we use 130 degree DHS.
Show the what is the preoperative pulse angle, what is your osteotomy angle, what is your target angle. You have showed that in the PPT. What is all that?
We actually didn't do the wedge osteotomy, sir.
See, whatever you're doing preoperative planning should not be done on CM. Should be done before surgery. You trace this whole radiograph on a tracing paper, cut the wedge and plan it how much you want to rotate. You take a short, small video of it.
Yes, sir.
Then your presentation will have more
Yes.
value.
So here we didn't remove any wedge osteotomy, sir. Just we have opened them on the medial side, and then medial open wedge endotrochanteric osteotomy. So this helps in achieving limb length. So the postoperative neck shaft angle is 130 degrees. Yes, sir. Medial side open, sir. Yes, sir. Yes, sir. It's just 10 days post-operatively. Sir?
Pediatric DHS or adult DHS?
Yes, sir. Pediatric DHS only. This is, yes, sir.
Intraoperatively, what you have done, intraoperative pictures, how you created the wedge, how you calculated the angle, how you got that 15 degrees of valgization.
We didn't remove any wedge here, sir. Just open on the medial side. Yes, sir. Yes, sir. Yes, sir. Yes, sir. No, sir. State immobilized for 6. No, sir, we didn't apply spica. but advised strict immobilization for the next 6 weeks. Strict immobilization we have advised, sir. Non-weight bearing. Yes, sir. Post-operative we advise strict non-weight bearing. Yes, sir. Yes, sir. The valgus angle.
Veto technique you have told the osteotomy is taken proximal to the lesser trochanter.
Yes, sir.
But here your osteotomy is at subtrochanter level.
Uh,
How are you so confident in your right?
Now that in different articles, in osteotomy has given differently, sir. In different articles, the site of the veto has given differently, sir. In Campbell, it has described distal to the lesser trochanter we have to take. But in this article, they have given us proximal. We have to take proximal to the. Yes, sir. Yes, sir.
Good morning, sir. This is an X-ray presentation done in Unit 3. 16 years old male with closed middle third sharp fracture of left radius. We have done ORI with 7-hole DCP for left radius. Yes, yes, sir. Fall from bicycle. Radials. Yes, sir. Yes, sir. "32-year-old male with we can mid prone. Mid prone, sir. Angulation has.
So radius will not undergo fracture isolatedly. There will always be a plastic deformation of the ulna that you have to correct. You have to correct the interosseous space. So what sir is asking is, if you want to conserve and treat it with a cast, what will be your technique? How will you keep it? With mid-prone, can you think with this amount of angulation, will you correct the interosseous space and everything?
Mouse.
No, no. So which position is better? So always there is different, for forearm fractures in pediatric, at each age there is different amount of angulation which is acceptable. Will you read those parameters and let us know?
Yes.
For 9 years it is 1, 9 to 13 it is 1, after 13 it is 1. So you read that.
Yes. 30. Little counts. Third one.
Right.
32-year-old male with 5 years old post-op status follow-up case of closed lateral hoof fracture of left distal femur with implant in situ. Yes, sir.
Joint is gone on the lateral side.
Yes, sir.
After removal or before removal?
Before removal.
Before removal, joint is destroyed. What's the age?
32.
Joint is removed. Pain is there or
No pain, sir. Patient wants to.
patient wanted?
This is a 51-year-old female with a 2 months old closed distal third both bone fracture of right leg. We have done a closed reduction internal fixation with ILN for right tibia, sir. We didn't fix it, sir. We didn't fix it. We just corrected the deformity and fixed the tibia. This is a 2 months old. Didn't disturb it, sir.
Primary bone grafting done.
No, sir. No bone grafting. Just only osteoclasts and internal fixation with ILN. This is post-op X-ray, sir. This is pre-ops. Yes, ma'am.
Sure, it is united.
Yes.
No, in reduce it, it come in position. Make it straight. Correct move. Right.
This is 50, sir.
Was done because so much osteoarthritis. 51 female, grade 4 osteoarthritis.
Yes, sir.
Standard drilling was done.
Yes, sir. 57-year-old male with closed comminuted middle third distal third junction shaft fracture of tibia and distal fracture of fibula of left leg. Distal, sir. Manual is within 7 centimeters of the joint. We have done closer direction internal fixation with ILN for left tibia and ORF with plating for fibula, sir. This is a 24-year-old female with chain cell tumor of a distal end of distal end radius of left wrist. So
What is it?
this is skeletally mature patient with a swelling in the distal radius. You can see it is a epiphyseal metaphyseal junction.
Joint involved here or not?
Joint is not involved, sir. It is subchondral in location.
Clinically, what do you think about what X-ray? Clinically, patient has come to what duration you have patient had?
Since 3 months, sir.
3 months only.
Yes, sir.
3 months only swelling is there.
Yes, sir. Before the 3 months, they have observed swelling, but within the last 3 months, it has progressed to this size.
So, what do you expect in a patient like this, 24 years, male or female?
Female, sir. It is a distal radius mostly,
It is slow growing or fast growing or what? 3 months it has grown up.
but there are no malignant features like weight loss or any.
Malignant tumor.
No, sir. This is benign tumor.
Benign tumor.
Giant cell tumor is
So, from it, is it benign tumor or malignant tumor?
rapid progression will be seen in malignant tumors.
Now, clinically, what did you find in this? These are physics of giant tumor.
Yes. Yes, sir.
Did you palpate completely the radius?
So she has pain, sir. She movements are normal, but little limited, sir. Yes, sir. No, no, sir. No, sir. Done MRA. Actually, these are done elsewhere, sir. So true-cut biopsy was done. Yes. It has given as a giant cell tumor or the aneurysmal bone cyst as a biopsy. Yes, sir. I mean, provision. This is. Yes, sir. Yes, sir. Usually, giant cell tumor is eccentric in location, sir. Yes. On the. Yes, sir. No, sir. Giant cell tumor. What, sir? No, sir.
Eggshell cracking.
Eggshell cracking. It is there, sir. Giant cell tumor. Yes, sir. No, sir. No, sir. Yes, sir. It is a pain. Pain is a chief complaint, sir. Increases the pain, not but not severely. Yes, sir. This is a. This is a tumor. You can see it is a distributed metaphyseal epiphyseal junction. It is eccentric in location, and
That is at the epiphyseal location, not metaphyseal. Next to the epiphyseal location.
and there is a so bubble appearance. As you can see here, small lobules. Here you can see.
Next epiphyseal location, osteolytic lesion. Expansion. There is no periaxial reaction. If there is pathologic fracture, you should mention that. Is there any soft tissue extension or any joint?
What is the matrix? Any calcifications? What is the soft tissue?
No, sir. We have done wide excision, sir. Wide excision with margin of 2 centimeters. Wide excision, sir.
What is this? What is this? What is that?
This is a distal radius. That is the exercise, sir. Yes, sir. No, sir. We didn't drain anything. This is a swelling.
దాన్ని 2-dimensional photo తీయాలా దాని పక్కన స్కేల్ పెట్టాలా
This is a fibular head graft, sir.
లాలీపాప్ లా ఉంది
Fibular head graft taken from the contralateral leg. Yes, sir. Fibular head.
so is there only head there
Fibula with fibula with shaft to compensate for the to replace the female head excision. So, wide excision with fibular grafting.
Okay, what was your plan after diagnosed with the GCD? What was your plan?
So,
So what were the options?
no sir.
చేసిరు కదా biopsy.
True cut biopsy. It yes sir. 3 grades. 3 grades. No sir. Yes sir.
It was done outside.
True cut biopsy was done elsewhere sir. The elimination of the just given as a giant cell tumor. More, more.
So you should mention whether it's a primary first line GCD or a recurrent GCD. Primary, it is you have the treatment options. You can do a Q-TAL program. If it's a recurrent GCD, expand size, fast growing, it has some potency to be malignant and have a recurrence. So that is why you are going with the excision first in the first instance.
Yes sir. Yes sir.
And what are the graft options you have? Can you do ulnar translocation?
Yes sir. But
What is the disadvantage of that?
Average joint reconstruction will be not as similar as the fibular head graft. Yes sir. It's 25, 24 sir. Housewife only. Yes sir. Yes sir.
Dominant hand or non-dominant hand?
It is a non-dominant hand sir. From the contralateral fibula. Not same sir. No, for walking purpose, when she is allowed to weight bear, it will be difficult if it is on the same side. You know. Yes sir. Yes sir. Yes, sir. Where there is an insertion of a biceps tendon, so this is biceps femoris. Biceps femoris to the head of the fibula. Yes sir, we have cut the biceps tendon sir. Once biceps tendon and LCR are excised, within I mean, yes, yes sir. Yes sir, we have secured a common burial now sir. We have to common burial is just located beneath the biceps tendon sir, and usually it is we can locate it with the help of it is surrounded by fatty tissue. By locating that yes sir. So we have secured it.
That's important in this cutting is not important. It should be common perineal nerve isolation. How they have done it.
Yes.
No,
Yes, sir.
Japani.
Yes, sir.
You are there.
Yes, sir.
Collect all the pictures of this case,
Yes,
your colleagues have it,
Yes, sir.
put it again properly.
Okay, sir.
It can be made as a case report.
Yes, sir.
Not done every day, no. Maybe once in 6 months you do such a case.
Yes, sir. Sir? Yes, sir. GCT only. No, sir. In if we are suspecting malignant transformation. So, yes, sir. Yeah, it will decrease the gene cell count and also decrease the size of the tumor. Usually, pre-op denosumab has a role, sir, but post-operatively it has shown there is no use of denosumab usage. Yes, sir. So, once the fibular bone is taken, it is fixed with a 6-hole small DCP, sir, and the wrist joint is to reconstruct the DRUG. We have applied one transverse K wire, and to prevent anteroposterior translation, we have applied crisscross K wires, and thus stabilize the wrist joints. And then post-operatively, we have applied a above elbow slab.
So while taking X-ray, a slab is removed and taken X-ray.
Yes, sir.
See, any GCT you have to evaluate metabolically. You have to take an ALP, calcium phosphate, PTH, parathyroid hormone. Could also have been a secondary, like I was saying, like a Brown's tumor, like a hyperparathyroidism. Could have been, but that has all has to be ruled out first. Second, with denosumab, what the problem is, it's a osteoclast inhibitor. So the problem is there no chance for recurrence at the same site. You already know it's an aggressively growing lesion. It's a lytic expansor like that side. 3 months of progression. So you don't want another recurrence. So already you have planned to excise it and put a fibula. So there is no role for denosumab in this case. You could have done if it's a less aggressive lesion. That's why Campanacci grading is more important.
Yes.
You have to grade the lesion, told what is the Campanacci grading, and then proceed with the procedure.
Okay, sir.
Forty-years-old male with compound grade 3 with middle third distal third junction shaft fracture of both bone of left leg and closed middle third distal third junction shaft fracture of both bone of right forearms. We have done X-fix for left tibia and ORIF with plating for right radius and ulnas. 47-year-old male with closed tibial plateau fracture with intra-articular extension and fibular neck fracture of left knee with no DNVD. Schatzker classification type 6. We have done CT, sir. We have done ORIF with dual platings. 53-year-old male with surgical neck fracture of left humerus. We have done ORIF with Phillos platings. 53. The head is in varus.
What type classification? How many
Knees.
parts?
2 parts. Knees.
2 parts. Okay. Yeah. So you want to? Can we treat non-operatively? Yes, we can. But operative also we can treat.
Yes.
Because undisplaced. Lakshmikant, can we treat? Non-operatively?
Head.
Udarai. Huh? Varus, will it make any difference? Maybe varus collapse happens, so I think justified. Okay.
You have done ORIF with fillose platings.
So here, pointer is there. Which is the most important screw?
Calcar screw.
Calcar. Which is the calcar screw? Show me.
Middle.
That's the one. Maybe long. That's the most important. So, if you don't have this purchase or whole fixation, it will go into varus collapse.
Neck shaft angle. Yes.
Okay. That looks good. Done?
Good morning, sir. This is a 44-year male with a cervicotrochanteric fracture of right femur. We have done a close reduction till fixation with proximal femoral nerve.
Okay. Probably, I think long enough probably.
Yes.
A long one, short one this is.
Short one.
Short. Okay.
47 years old female with 10 years post-op follow-up case of tibial plateau fracture of left knee, sir. She was presenting with pain in medial joint tenderness and we advised implant removals.
Okay. So what's the problem with her? You removed it. Will it solve our problem? No. What was the problem?
Since he's 62, osteoarthritis might be
Your joint space is reasonably preserved.
main there.
Yeah. So you had to get, probably she got osteoarthritis. This is not weight bearing film. Is it
No.
weight bearing film?
No, sir.
No. I think she would benefit from corrective osteotomy.
High tibial osteoarthritis.
That's called preservation of the joint.
Yes.
Get her alignment, long leg films. Okay.
18 years old male with closed middle third bone fracture of right forearms.
Okay.
We have done open reduction and tunnel fixation with plating for both radius and ulna.
Looks good.
A 64-year male with 3 years post-op case of left fibular fracture, sir, with implant in situ.
What is that? Look at
The
that.
list.
Is that a loose piece or? No.
No, sir.
Is that a loose piece?
The dish, sir.
Is it
Discharge
affected?
sir. Yes.
But is that a loose piece or not?
It's not seen.
Yeah.
In AP.
So I think probably superimposition may not be loose piece. Yes.
I've done implant removals.
And debridement done.
Yes.
Okay.
There's a 23-year male with a 8 months old post-op follow-up case of closed middle third shaft fracture of right femur, sir. We have discussed last week. So we have done a screw replacement, a distal screw replacement, and dynamation and bone grafting. Open at the fracture side and bone grafting, sir.
That was easy to remove.
Sir.
That was screw was easy to remove.
No, sir.
You removed it anyway,
we
but
removed
difficult.
some.
Okay.
Yes, sir.
Mm.
We opened medial side also.
Okay.
Then same length screw is inserted in the same hole and drilled, sir. That's,
Final X-ray. This, right. Looks good.
this is a bone grafting, so we filled a lot of bone graft.
Okay.
This is a 13-year male with triplegic cerebral palsy with equinocavalvirus deformity of left foot, sir.
Okay. What was done?
So, TA lengthening with jetplasty and posteromedial soft tissue release and modified Jones procedure for first
Big toe.
external tensor, sir. Extensor Hall system.
Okay, good.
This,
So deformity was corrected?
Yes, sir. We applied an above knee plaster.
Okay.
This.
Okay.
23 years old male with comminuted surgical neck fracture of right humerus, sir. This
You know the class?
right,
See,
yes.
this is 23, but is he really 23?
Yes.
It looks very, doesn't look like 23. Sridhar? So you don't have other view. You have lateral view, axillary view? Why? Okay.
We have done CT, sir. Here we can.
You
see
understood
there
what
is
he said?
Yes.
Very important. I think you should, next week probably, Sridhar, you take proximal humeral fractures management, classification management. One class. Yeah, go on.
We have done open reduction internal fixation with Philos plating, sir.
But this, go back. This reduction is not satisfactory.
Since it's comminuted,
See, this is going that way, isn't it? That's why its height is not restored. The rotational deformity is not corrected. But anyway, it looks good. The tuberosity is below the level of the head. The most important is tuberosity should be down level, which is almost same level. Okay. Yeah.
The 61-year male with the lateral malleus fracture and fracture dislocation of right ankle, sir.
Okay. Why 2 screws?
For syndesmotic.
One is enough. And it's should not. Syndesmosis is not a compression screw. Fully threaded cortical screw should be. Okay. Just leave that tricot.
even pre-op X-ray, there was a. Normally, the tibiofibular overlap should be more than 10 mm, sir, and tibiofibular clear space should be less than 5. But both of them are deranged.
But this is at the level of, it's a B, type B. Unlikely syndesmosis is unstable. Who has done it?
70 years old male with closed distal and femur fracture of right knee, sir.
Oh.
This is Muller's classification B2, medial condyle fracture. And in CT, we can see there is another anterior coronal fragment as well. Here. So we have done open reduction internal fixation with medial
Can somebody
LCP
shut
and
the
a
door?
Herbert screw for coronal fragment.
Go on.
Mm. 34-year male with a 2-year, 4 months old post-op follow-up case of closed middle third both bone fracture of right leg, sir, with implant insert.
Okay.
Implant removal. 63-year female with fracture neck of right femur.
Mm.
Basic
Complete,
survey-
incomplete.
Sir, complete, sir.
Oh, okay.
We have done bipolar cemented hemiarthroplasty.
Not much of cement. Okay, gone.
65-year female with intertrochanter fracture of right femur.
Mm.
We have done close reduction internal fixation with proximal femoral nerve.
Okay.
This 52-year female with the close subtrochanteric fracture of left femur. Sir.
Mm.
We have done close reduction internal fixation with long PFNs.
Why not recon nail? Could done this one, but I think. Lakshmikant, can we do recon nail?
So
Go back.
Pathological.
Very cortices are okay, maybe X-ray. Okay, there is doubtful, isn't it? This is maybe D3 deficiency. Metabolic disease maybe.
Yes.
Investigate for metabolic disease.
Okay. Sir.
Okay. Done?
One more unit.
One more. Second unit. All right. Only one case or?
3 cases.
Okay. Done.
Good morning, sir. These are the cases done under Unit 2, sir. 70-year female, closed distal third both bone, soft fracture of left leg.
What else he got? Go back. Anything wrong?
Sir,
Third leg? Look at the
pathological-
top.
pathological fracture.
Huh?
Pathological fracture.
No, what is there?
Osteoarthritis changes.
Severe osteoarthritis.
Yes, sir.
And it is osteoporotic.
Yes, sir.
What mode of injury?
Sir, fall, sleep
But
and
lighter.
sleep and falls.
Right. Okay. Okay. Good. Okay. Next.
We have done close reduction internal fixation with interlocking nail for left tibia. 45-year male, grade 1, compound proximal middle third junction, both bones, soft fracture of left leg, sir.
Mhm.
We have done close reduction internal fixation with interlocking nail for left tibia.
Okay. Did you start antibiotics pre-operatively?
Yes.
Okay. Good. Next one.
55-year female, 1 week old, intracapsular fracture of neck of left femur. We have done hemiarthroplasty for left hip joint with Austin Moore prosthesis.
No cement.
No cements.
Who has done?
Ragis.
Should be cemented. Length is okay. Almost okay. Maybe little bit of cement would. Otherwise, they'll get anterior thigh pain, because if it is loose, thigh pain and it will sink. There's a lot of there's space around. The problem with this is there's no. What is that? Different sizes of the stem. Its entry is too medial.
Yes.
It's a varus. They fail. Okay. Rakesh is here. Oh, you're here. So cemented is better. Doesn't matter. We have to cement it. Now, there is a space. You can put cement there. Okay, they'll develop, and your entry was too medial. Should have been there. So valgus is okay, but varus, it should be there in line with this one, and cortex is good. So especially, how old was he?
55.
55. So young patient, it will need revision.
No,
But
65.
bones are good. Look, quality of bone is very good. It looks 50 rather than 55. Okay, next one.
That was
That's it. Good. First year people, this one, thesis topics were given.